we have with us Dr. Arvind Krishnamurthy. Sir is heading the Surgical Oncology Division in Adyar Cancer Center, one of the oldest cancer institutes in the country. So, good afternoon, sir.
Good afternoon.
So, welcome to CanCon 5th edition, sir. So, it's a privilege to have you with us.
It is my privilege as well. In fact, I must say that I've attended every MVR CanCon till now, and this is the fifth, and I'm enjoying, and I've enjoyed every earlier CanCon, and I'm having a good time here as well.
Okay, so it's not the first time in our campus, beautiful campus here in Calicut. And so you are heading the one of the oldest cancer centers in the country. So, what legacy do you wish to leave behind, sir? And what message you want to leave to the youngsters, basically, who are just passed out from the MCH?
Of course, I must say that whatever little I am today is thanks to multiple people, effectively, at least in the professional world. Whatever little I'm here today is because of my teachers at the Tata Memorial Center, Mumbai, where I did my super specialization in surgical oncology. Of course, if I go back earlier, thanks to all my parents, my family, my friends for supporting every endeavor of mine. And of course, when it came to the professional world, I think I owe it all to the institution. So it's really sort of given me a different perspective. I would have loved to sort of continue my stint at the Tata Memorial Center, but because of family needs, I had to relocate to Chennai. And I was always an institution man. I always wanted to work in high volume centers. So after my course got completed at the Tata Memorial Center, I immediately joined the Cancer Institute Adyar as an assistant professor in surgical oncology. And it's been close to 20 years now, and slowly I have sort of risen to the rank of professor and head in the surgical oncology division.
And so, over these years, you said it's almost 20 years.
Right.
So, what change have been seen in the cancer landscape in the initial part of the 20 years and currently? Is any like drastic change or any like what do you see? Like anything you like actually point out something?
Right. No, it's changed. I think I must say that cancers, like any other field, is constantly evolving. Our understanding of the disease is getting better with time, and there have been advances across specialties. For example, even in surgical oncology, when I used to train, of course, open surgery was by and large the norm at that particular point of time, but I had a fair exposure to minimal invasive surgery in the form of laparoscopic surgery and video assisted thoracic surgery. I had a brief exposure, but I think over the years, the robotic technology has, in a way, revolutionized the way we practice cancers across various subsites. In fact, in certain subsites like head and neck, where I feel initially I felt that the transoral robotics was just being thrusted upon us. But I think over the years, I've realized that it does have a very distinct role to play, even in head and neck cancers as well. When it comes to many other cancers of the body, in the thorax, in the abdomen, in the pelvis, be it abdominal, gastrointestinal, urological, gynecological, I think the robotic technology has, in a way, revolutionized the way we are currently practicing oncology. Of course, as we await long-term results of this technology, but we must say that we are seeing very faster patient recovery. Short-term oncological outcomes are definitely better. So I think from the surgical perspective, I am seeing a lot of change towards minimally invasive surgery. Of course, the other thing that has happened is the tremendous advances in systemic therapies that have happened over the years. Initially, when I was training, it was only chemotherapy, hormonal therapy. But now, with the advent of immunotherapies, initially it showed promise in the metastatic space in many cancers. Uh, Slowly, it is coming into the realm of adjuvant as well as neoadjuvant space, and lung cancers, for example, which is another cancer which is a area of keen interest to me, has sort of revolutionized the immunotherapy, has sort of revolutionized the management of lung cancers. Now we are talking about neoadjuvant chemotherapy and immunotherapy, even in resectable lung cancers. And in certain cancers, what has happened is the systemic advances have been so tremendous that we are seeing dramatic responses, that in certain select cancers, we are now talking about no surgery. For example, in rectal cancers, in esophageal cancers, there are some studies that are underway. In breast cancers, the talk is there. And I'm sure in many other cancers, the talk of avoiding surgery completely is there. Of course, it is very, very early days. Right now, the standard of care continues to be surgery in a majority of the cancers. But the way that we are seeing tremendous responses in a select group of cancer patients, this approach seems to be very, very promising. And I feel that surgical oncologists in the years to come should adapt themselves and embrace these technologies or these advances, because ultimately we are here to sort of better outcomes for patient in terms of oncological outcomes, and also better outcomes in terms of their quality of life. And I feel the systemic advances have sort of revolutionized a lot of treatment. And the other thing, of course, in radiation, you have a lot of advances in the way targeted radiations are being developed, including protons, which is coming up. A couple of other centers, a lot of advances have happened in the space of precision medicine, I must say. Earlier, we used to have the one size fits all approach for every cancer. And I feel that in the years to come, the genomic landscape of every cancer is going to be studied in much, much more detail. Of course, at this point of time, we are talking about it in the metastatic space, but I'm sure that in the years to come, we will be studying the genomic landscape of every cancer, possibly at diagnosis, and maybe we will be personalizing treatments for them. So it's, as I say, the advances have happened not just in surgery, in in radiation, medical, in precision medicine, and all other allied diagnostic facilities as well.
Yes, sir. Okay. Okay, so basically, as a surgeons, we wish to see the patient first, and we wish to do the surgery first without before he takes any other thing. The theme of the topic today in CanCon is salvage.
Right.
So, as a surgeon, how do you approach patient comes to you after refractory, after multiple treatment failures? So, should we be the surgeons as first to deal with this kind of patients, or then or we have to send to med-onco? So there's a bit of dilemma in this. Different cancers, it's different. But actually, I was specializing head and neck. So who you should take the lead in treating some kind of patients?
No, I think that's a very important question and a fully loaded question. And I'm happy that the with every MVR CanCon there has been a different theme, and the theme for this Congress is salvage, which is a very, very important and relevant theme as far as I'm concerned, and very particularly in head and neck cancers, we must say. That the recurrent and metastatic space, we have a lot of unmet needs which are there. So, evidences are evolving, so it's important that all the decisions are taken in the realm of a multidisciplinary tumor board, wherein we have members of all the mainstream specialties as well as all the support staffs and allied specialties as well. And I'm sure that each of the specialties would have a particular role. So, of course, salvage surgeries are there. Traditionally, they have been there, and we should be very judicious in choosing that approach. There are options of re-radiation as well after a particular time frame, but more impressive advances seems to be happening in the systemic space. But at least in head and neck, there seems to be a dearth of progress in systemic therapies. We have seen, of course, the promise of the extreme regimen way back in 2007, and then, of course, it took almost a decade to for immunotherapy to come up in the metastatic space. But I feel that still there is a gap that we need to sort of understand. So we know that by sequencing some tumors, we do get some targets, but somehow we are not able to make very remarkable progress in head and neck cancers, especially. We are able to make progress in other cancers, for example, in lung cancer, breast cancer, and many other cancers, with many other common cancers that we see, we are able to see some remarkable systemic progresses. In head and neck space, the progress is there. It's been slow, but I feel the years to come, we should be seeing more progress. And I also strongly believe that, considering the fact that we are one of the world number one in terms of oral cancer numbers, I feel the change should be coming from us. We are already seeing this, where the world is looking upon our country to sort of have some amount of systemic advances. And I'm sure in the years to come, we will have more data coming up from India in this space as well.
So, thank you for your brief interview, and thank you for having you with us. And also, we should like to like call you for the next CanCon. Also, definitely be in the this thing. So, thank you, sir, so much.
Thank you. I think it's always been a pleasure to come to this part of the country for various reasons. For the institution, I've seen this institution grow over the years. A lot of our alumni from the Cancer Institute are also here in leadership positions, and it's very impressive to see the growth of many departments, not just surgery, but even the allied departments of even nutrition, psycho-oncology. A lot of people who are trained from our center are here. So it's very impressive to see the growth of MVR Cancer Center in a very short time that it has been here, for maybe 7 or 8 years. And I wish this center many more laurels and successes. And I would be happy to be a part of any academic endeavor, including the future MVR cons as well. Thank you.
Thanks so much.